Well, good afternoon, everyone. Thank you very much for joining us today in this virtual internship presentations. We will begin with Dale Henion's presentation, and at 2 p.m., we will continue with Tia Carmen. Both Dale and Tia are students in the Masters of Professional Science in Biomedical and Health Informatics program. And for the last few months, each of them has been working on hands-on projects, and today represents a culmination of their hard work. They will be presenting an overview of their internships as well as key findings. So let me start by introducing our first speaker, Dale Henion. Dale works as a manager of cardiac and vascular ultrasound services at UNC Hospital. He will be talking about his work with the Cardiac Catheterization Lab to support research and quality improvement efforts. Dale, thank you so much for being here today. You now have the floor.
Great, Mariel, thanks. So I'm Dale Henion, and I've been working at UNC for the last 14 years, and I've been in the CHIP program for the last 3 years, part-time, mostly part-time, full-time at times. And this internship program, arose organically out of the greatest data need that I observed for the cardiac cath lab, which is where they put in stents and do other revascularization procedures for the heart and treat people with heart attack or prevent people from getting heart attacks. So their greatest data need was obtaining post-discharge outcome data, including readmission and mortality information for their patients post-discharge. So this project I worked with them on the goal was to link their cath lab registry with the electronic medical record information in order to capture post-discharge readmission mortality tracking. There we go. So to provide some background, as we've strived to transition from a fee-for-service model to a fee-for-value healthcare system, registries have played a more important role, and the participation and interest in registries has grown. At UNC, we have over 200 registries just at the medical center that we participate in. And when I'm talking about these registries, I'm not talking about local registries created for specific projects. I'm talking about nationally governed registries, typically by the professional societies within each area of disease. So I'm showing just a few of them within cardiology. And the project that I'll be speaking on today has to do solely with the Cath-PCI registry. However, the trends, I should say the systems and strategies that I illustrate may be widely applicable to other registries as well. So how we use this data is supremely important, and it deserves a lot of attention. And so I'm going to start by illustrating the background process that we currently have across most of these registries. So information is entered into the electronic medical record at the provision of care. That we have trained generally specialist nurses that are trained in abstraction to then extract the information out of the medical record. They enter it into another database, and that database transfers the information to the registry body, the formal registry body. And then we generally wait a minimum of 6 months. Currently for this registry, we've been waiting for closer to 18 months at this point since we've received any outcomes from it. There is a reason. It's because they underwent a version change, but nevertheless, even though we haven't received these results, life has gone on, quality still matters, and it's just one of the many pitfalls that we need to fill. So My project, I'm keeping this in mind as the background because in developing our own database to capture this data and improve on the data set that we have, we want to it's my goal to fix as many of these issues as possible. So the problem with waiting 6 months before you get registry data back is that it's, okay, so while quality improvement, formal quality improvement methodologies is still in its infancy within clinical care improvement, the formal methodologies for quality improvement all rely on quick iteration, plan, do, check, act cycles, and kind of a quick to fail approach with rapid iteration. So waiting 6 months or more before you can even get results is really stunts any quality improvement processes. And the registries ultimately function to support quality improvement. We have hundreds of fields within these registries, and there is no data source with a higher amount of quality data than the registries because of the amount of vetting that goes into getting the data, the amount of data fields that are within them, and there's clear definitions that spell out every single data point. So the accuracy is unparalleled. However, the process needs improvement. So after we do get the reports, we generally get like a kind of a report card type of format with hundreds of fields. And if you pay a lot of money, generally they have somewhat of an analytic interface available, but it's limited. So that brings me to the next challenge, which is that now we have hundreds of great fields that we can build, we can analyze and build quality improvement projects off of. However, in order to know how to improve, you need to have a good analytic interface to do that, to uncover correlations across these hundreds of fields. So a report card format just is not adequate for discovery. And then the third element that I've mentioned that which is really behind the whole goal of this project, is that the outcomes that are included in these registries, or in this registry particularly, and it's for many others as well, is the outcome is only up to the point of discharge. But the most important outcome from the patient perspective is, how do they do after they leave the hospital? Do they die? Do they live? Are they readmitted? If they're readmitted, what are they readmitted for? And so providing this post-discharge readmission mortality information adds a whole layer of value and offers a lot of potential to improve the usage of this data. So to reiterate my initial goals of this project, it is to decrease the delay of getting and using registry data, to add post-discharge readmission and mortality outcomes to the data set, and to provide a front-end user interface for analytics. So this is my solution model here. It's a simplified solution model. So we're dumping the electronic medical record into the Carolina data warehouse. This is already the case. And so I want to dump all the registry into the Carolina data warehouse as well. And then we immediately solve two of the problems. We have access to real-time reporting, and we have the analytic flexibility with interfaces such as Tableau or Business Objects to do all of the investigatory work that we please for information discovery. All right, so the first leg of the project was to get the registry and dump it into the Carolina data warehouse. On the right-hand side of the screen, you see these are buckets of categories for the registry data. So you can see there's quite a bit. We've got everything from demographics and insurance to history and physical information, all of the tests that they had before the procedure, medications before the procedure, procedural details, details about the clinical visit, details about the findings within the procedure, stenosis, the devices that were used, the events that happened after the procedure, discharge information, and the medications they were discharged on. So immediately, just by doing this, we actually have a very significant accomplishment under our belt, because this information, while it was being entered into a third-party database, it was the abstraction software provided by the registry body. Those databases are not widely accessible, and generally only the abstractor has access. And that's a severe bottleneck, because abstractors have quite a full-time job on their hands already. They are not ideally suited to be working on quality improvement or research projects. So by dumping this into the data warehouse, now we have access on a system level to all of this data. All right, so the next step of the project was to get the readmission data post-discharge. And fortunately, collecting readmission data is not a brand new idea. So I reached out to the enterprise analytics folks in Morrisville, and they educated me on our current tools that we have for collecting readmission data. I customized those tools to function for this project. So what I'm demonstrating here in this diagram is basically there's a readmission query that allows me to dump all the account numbers, which are case level specific identifiers, into the readmission query, and then that will retrieve the very next readmission or the very next admission, and I defined it to be inpatient in the query. So I'm getting the next inpatient admission for each of those cases. And then I built metrics after capturing that data to define the time intervals between discharge and readmission at 30, 60, 90 days, and 6 months and 1 year. And this is significant because most readmission work and tracking has been focused on a 30-day window. And being able to open it up past that up to 1 year is significant, because we can not only focus on the immediate outcomes and early readmissions, but it opens the opportunity to look at care coordination and more long-term follow-up. And these are chronic diseases underlying most of the pathology that enters the cath lab. So care coordination and follow-up deserves attention, and this, just extending this infrastructure to better support that, I think is important. So the next leg of the project was to get the mortality data. I was a little surprised. I dug around quite a bit and collaborated with everyone I could find who had been working with mortality data. And I basically found that the road was actually unpaved. So I ended up building the most comprehensive metric I could within the data warehouse to capture mortality data. And since then, it's been this measure that I made has been adopted for a hospital, or actually for system-wide mortality tracking. So it's pretty simple. It's essentially, I capture a deceased indicator. Some people are simply just marked as deceased within Epic. There's an Epic date of death as well. And then there's a state death. We have a state death database, which also dumps into the Carolina Data Warehouse. And so by combining the three of those, we come up with the most comprehensive and accurate mortality indicator. And so that's what I obtained there. And then similarly, like I did with readmissions, I defined intervals at 30, 60, 90 days, 6 months, and 1 year. In dealing with this data, this is where it really hit me how important those intervals were. You may have heard someone say before, your mortality rate will be 100% given enough time. So measuring the time from discharge, or the time actually of the procedure to the date of death, is supremely important for any work we do with mortality data. Okay, so now I'll move into the results of this project. So the query that I ran after putting all this together extends from July of 2014 to December, the end of 2018. The reason that the reason I start in July of 2014 is because that was actually when we went live with Epic, our medical record system here at UNC. So there's a lack of data to correlate to before that. However, I can get the registry data for the cath lab dating back to the early 2000s. So that's neat. But for this project, I needed both data sets. And then I ended the data set in the end of 2018 because that way I could get an entire year of follow-up information throughout the year of 2019. And there was a total of a little over 12,000 cases and 10,000 patients within this data set. And you can see them charted out by year here. Again, the 2014 data set is only representing half a year, which is why it's less. And so it's important to note that between the two data sources of the registry and the medical record, I had a 99% identification match at both the case level and the medical record level. And in case I didn't say this already, the difference between cases and patients demonstrates that many of these patients had multiple cases, which also infers another point of significance of this project, which is that it allows us to look, for the first time, it allows us to look longitudinally over time at any given patient or group of patients and their results and outcomes. So here's a summary of the outcomes. I'm sorry, if you hear construction behind me, it's a permanent condition here in the neuroscience hospital. So mortality ranged from 30 days, at 30 days, a little over 3% to almost 8% at 1 year. And this is across the entire data set. And then readmission from nearly 7% all the way to nearly 24% at 1 year. And you see this extra category over here without date. If you recall, one of the mortality metrics that I used was an indicator, or simply a deceased flag that does not always have an associated death date. So sometimes a frontline person might learn that someone is no longer living, and they will mark that in the chart. However, the death date actually never becomes known. So that's a small percentage, but important to account for. All right, so now I've grouped them by socio-demographic characteristics here. And this is where the project started to get really fun because this is only possible because we're combining the two data sets, the medical record with the outcomes of readmission and mortality, now combined with all the registry variables. I'm only showing a few here, but now we can group these outcomes across socio-demographic characteristics. So you can see I've included just a few: gender, age, insurance for both mortality rates and readmissions. I added a race category to the readmissions chart here on the right. And one question you might be asking is, why are there only two race categories? But the answer is because I have more, but unfortunately the data is the volume of patients seen in minority races was really not adequate for analysis. So it's really misleading to include it. And another thing you'll notice is that I'm displaying both mortality and readmissions over time. So it's grouped by year as well here. And here I'm continuing to look at it by characteristic, sorting it by characteristic from the registry data set, but I'm only looking at 30-day readmissions on the right. And this is showing a few comorbidities and how that impacts readmissions. you can see dialysis is a very significant category, jumping up to 29% in 2014 for 30-day readmissions. Heart failure is another one, and this is body mass index down here, and you can see how that varies, and that's just for 30-day readmissions. On the right-hand side of the screen, I've showed a trend of the rise in readmissions for across these comorbidities: dialysis, glomerular filtration rate, which is a measure of the function of the kidney, heart failure, ejection fraction, and peripheral vascular disease. And you can see these are categories with particularly high readmission rates. And you can see after 30 days how steep the rise becomes. So by 1 year, the readmission rate for these patients, for some of these patients, some of these groups, goes all the way up to approximately 40%. And again, that just demonstrates the opportunity that we have to improve outcomes with projects that are focused more on care coordination and follow-up. So I just want to demonstrate, as part of this project, I built dashboards, and I'm not going to spend much time on them, but I wanted to, because all this information became available kind of all at once, and the ability to group data by across all the patient characteristics is potentially very powerful. I built it out into dashboards so that we could quickly and easily see opportunities for improvement across all major patient characteristics. So I'm just going to scroll through, and you can see all of the different characteristics that are available for a snapshot analysis in a dashboard format. So gender, peripheral vascular disease, dialysis, heart failure, body mass index, cardiovascular disease, chronic lung disease, diabetes, dialysis, hypertension, smoking history, whether they've had a prior, this is PCI is a catheterization, the indication for whether they were symptomatic or asymptomatic, the status of the procedure, was it elective, emergent, salvage, or urgent, and the ejection fraction. And all those characteristics exist for each of these tabs here. So that's mortality over time. This is readmission over time. This is mortality, not over time trended by year, but rather this is a view of the 30, 60, 90, 6-month, 1-year follow-up intervals. And that shows the, so these are the socio-demographic characteristics up top, whereas down here, these are more of the clinical comorbidities. And I have all of these for the readmission as well. So now I want to talk about the advantages and potential utilization of all of this. What I just displayed was really, those dashboards were built to provide a snapshot insight that we've never had before, rather than having to come up with an IRB just to gather the data and see the data. My goal is to make it as transparent as possible to operational physicians, and to inspire quality improvement work. So the first advantage in this project is data accessibility. I've talked about this a little bit, but now we're starting to talk about the utilization. So when we have all this together in a database, I've built easy filters that can be selected for the database, and that will filter across all patient level details, all those buckets of variables, plus all the group analysis. So when I was showing my preceptor, Dr. Rossi, what I had done, he said, okay, well, that's interesting. So what would we do for this research project? We have a funded research project right now in collaboration with Duke, and we're collecting, we want to look at all patients who have been readmitted for surgeries post their catheterization. And so we want to see all patients who are readmitted for either surgical events or bleeding events. and we want to capture these variables, and we want to define this specific patient population. And so I said, okay, wait, hold on a second. Let me just drag the readmission characteristics, the primary readmission DRG, over to the filter column. And then I went through and I started checking all of the surgical primary readmission codes. And so within 15 minutes, or approximately that, all the information across the entire deck had been filtered. Not only that, so we were ready, it supplied all the information that we needed to start the research project. And not only that, but we had the outcomes auto-calculated in front of us for the entire cohort, both readmission and mortality. So we saw immediately this had a lot of potential to really streamline practices around our research processes. And so yesterday, before this project, in the cath lab, our research processes really were hinged on manual abstraction and ad hoc ISD requests, which are riddled with communication challenges and logistics that really can slow up the process. After this project, for any research that's done for cath lab patients, we now have all the information that we need from the patient's history, from clinical characteristics, and outcomes, easily accessible, and we can just click on the report filters and have the entire data set at our fingertips with outcome analytics auto-populated. So we immediately before the formal internship project ended, we immediately started building out this cycle, and we reached out to TRACS because now we need to talk about compliance around research processes. So we partnered with TRACS, and we formed an arrangement you may be familiar with, where they have set up an honest data broker. And this honest data broker lives on the operational side of things, like I do, within a specialty, and they represent TRACS in, they act on behalf of TRACS in acquiring and exporting data for research purposes in the case of a developed analytic asset like this that facilitates the data capture and abstraction. So the process now goes like this. So we've built a team-based approach that starts with someone sitting down with me who has either a formal IRB already written up or an idea, and we will pull up the database and do some data exploration. I'll click on the filters that's needed, and we'll explore the data. We'll validate the project. We'll immediately see the outcomes attributed and whether or not the project is worthwhile to pursue and what our obstacles may be in getting data. If the IRB request wasn't formalized already, then they will do that based on our validation of the idea. Then I request approval from TRACS to my own data set to export for purposes of this project. TRACS provides us with a research folder, which is under their authority and surveillance. And then we can export the data sets onto that research folder, which are shared among our team, which now includes statisticians as well. And so we meet with them regularly, and the PI will revise what's on the shared folder with the statisticians and go back and forth until it's ready for publication. And then ideally, our work is re-implemented as quality improvement, and the process continues as we iterate towards higher quality and ways to innovate better practices. So I'm going to go back to the next advantage and utilization of this is that we can customize this analytic asset and this database for each individual quality improvement and research project. It's as simple as customizing the views that we want to see, using the filters that we want, and then saving the file as a new file. And then I can automate that file to run automatically in the background without any contact. I can automate its run, and I can even automate its email recipients. And that's particularly helpful with quality improvement work. When we have a team who expects to see certain metrics and their progress on a regular basis, this can be automated. And so this allows us to really scale the database to support many research and quality improvement projects simultaneously. So I'm going to talk a little bit about quality improvement. And to be quite honest, this work has kind of taken place after my formal internship period was up. But I had a chance to start on some of this. So one of the, when I say quality improvement work, this is outside of any research work that's already been done. This is kind of based on conventional practices and or best practices that are recommended right now. And so one of our major focuses in the cath lab is to decrease acute kidney injury as a result of contrast. So because I'm collecting case level information, I can, this chart here shows the creatinine before procedure, after procedure. I made a measure to, this is a measurement I created for the creatinine increase between pre and post, and then the percent increase. And then I wrote an algorithm that will automatically use those 4 measures to appropriately categorize the case as having no kidney injury, which is a blank here, or stage 1, 2, or 3 kidney injury. And then this is an automated a report card format that I've created to track these. So you can see the across the months here. This is recent data. Automatically staging cases that were stage 1, stage 2, and stage 3 for kidney injury. I'm showing the creatinine check rate as well, because unfortunately, once you let everybody know that it's a tracked measure, there's a tendency for providers to not take mandatory checks as often for fear of it hurting their scores. So capturing the check rate, the post-creatinine check rate, is, maybe one of the most important measures here, because it demonstrates an honest, good faith effort towards actually tracking this information, which is really the first step to quality improvement. So there is room for improvement there, as you can see. That's ranging from 64% up to 76% check rate. And then also I threw on this chart a tally of access site bleeds, which is just another quality data point that's it has a lot of focus on it, and they've been putting a lot of effort towards decreasing access site bleeds ongoing. So in summary, we've successfully linked the cohort across the data systems. We've successfully automated outcome tracking, including mortality and readmission rates post-discharge that were not available prior to this project. And we've enabled subgroup analysis of the mortality and readmission rates. And finally, we built a valuable asset for research and quality improvement. I wanted to share my vision, which is continuing to fuel my work for this project and like projects. I'm representing here the 3 aspects to my work and my focus. I'm representing them as gears because the way I've seen it is we have these registries, which are immensely powerful and have tremendous potential. I mentioned no other data sources are like this in the quality of data that is offered. And each of these cranks or gears currently exist separately, and even the teams that operate them are typically separate. And it takes an individual effort to turn each one of these gears. My vision really is to do everything possible to bring these gears together so that the momentum and the gains from turning one of them provides the leverage and momentum to move the others. And to take that a step further, in my view, this is a way to actualize a learning healthcare system. We have the registry data, which then feeds our research processes, which then informs quality improvement activities, which then is used for real-world data collection and transforms the quality of care, which is then goes back to reinform our research. And many people have been highly influential in this project, first of which is Dr. Joseph Rossi. He is the Cath Lab director, and it was his original inspiration. And Dr. Matthew Cavender, his partner in the Cath Lab, he's an avid researcher as well. And the need for this project was voiced by both of them over a period of years. And so it was really their inspiration that led to this work. Jennifer Lukes is the director of cardiology, and she is my boss. And without her flexibility, I absolutely would not have been able to technically maintain 40 hours on the clock while doing this internship, much less this entire program. Jenna Killoran is a executive analyst over in EADS, and she was the person who educated me on the readmission tools. And honestly, that was one of those points in this project where I really was kind of at a dead end, dealing with fields and trying to figure out how I was going to obtain this data. And it was invaluable. Her collaboration was invaluable. And Sean McDonald from ISD, I've worked with him for years, and he just continues to always be an amazing resource and provides a lot of insight and support whenever I'm able to get a moment of his time. And then finally, this program has been just tremendous, and it's transformed my skills and my outlook and my daily work. So I'd like to open it up to any questions. Is everyone still there?
Hi, Dale. This is Javed.
Hi.
That was a fabulous presentation. Thank you for doing a really nice job in terms of coming up with a problem and then following through and demonstrating how this ultimately would be not just produce some of the answers we're looking for. What I liked was that you developed it in a manner that's hopefully will be sustainable over a period of time. Just going back to the lag and getting data into registries, you had a slide at the beginning of your presentation. Yeah, like, yeah, right. So the 6 months lag. I was wondering, what is your reflection now that you have finished it? How was how is that potential problem going to be addressed?
So that's a great question. So the reason for the 6 month lag primarily is I'm kind of a little bit guessing, but this is a standard lag across all registries.
Hmm.
I believe that the lag is primarily due to the aggregation of data
Hmm.
by the registry body from all entities and risk adjusting and benchmarking the data. So that will continue to, that will always have a place. And from working on quality improvement projects for the last few years in different committees, I think it's a bad habit, actually, there's an overemphasis of benchmark data, in my opinion. So what happens is people get their report card back and they immediately say, oh, well, I'm an A, so I'm good. Or I'm a C, so I guess that's pretty average, that's okay. And they either generally rationalize the way they're doing things, or they get the meaning out of comparing themselves to others. And when truly, quality improvement work, benchmarking has its place, but quality improvement work is really hindered by that process, because you don't need to have benchmark data to other facilities in order to improve from your own performance, which is ultimately the goal, is to improve your own performance. So, so by eliminating that lag, we can, we're gathering all of our own data and just feed it into our own database. What we're doing is we're skipping the benchmark step and not getting risk adjusted data, and rather just using the raw data for quality improvement. So that's the trade-off, and I think they both have their place. And now that we're using raw data, as soon as the information goes into the chart, in this case for the cath lab, as soon as the information goes rather into the abstraction software, it's then communicated to the data warehouse. And so that happens within 24 hours, generally speaking, for the cath lab. So it's very quick. And so we can see data, we can see and utilize data on a daily basis. The potential to improve that even further is absolutely there. And you can see from this process that it's very clunky. And there's a lot of work, I think, on the industrial level, from corporate, bigger corporate bodies to streamline the process of getting data into the abstraction software. And we can, in the future, we're going to be pulling the data directly from the chart rather from the abstraction software. So I think ultimately we'll see that we're going to be able to skip that step as well, and even get data in real time. Did that make sense?
Yeah.
I might have lost you all. I talked a lot.
No. Thank you, Dale. That's helpful. That's helpful. Yeah, I just had a follow on. So in a subsequent diagram, you showed how it comes into the CDW, the raw data, and this process of getting that data into the CDW, there is some form of ETL being done, right? To transform it into the format that CDW would accept.
Right.
I'm just curious in terms of process, how long did that take in terms of creating the ETL, and how did you manage to accomplish that?
Great question. So fortunately, the ETL had already been created.
Mhm.
I'd done previous work. I've been working with the Cath lab for years. And so there were a few data fields, not many, but there were a few that had already been pulled into the Carolina Data Warehouse. So
Mhm.
I was just building on top of that work. And I did not do, I orchestrated that component of the process. I did not do it.
Okay.
Uh, on my end, all it was submitting a ticket and providing them a list of all of the database names that for each measure, and submitting that request. So I submitted, my request had over 300 data fields in it that I wanted added, and um, it actually was done within the period of this internship. And actually, I guess it was actually complete right at the end of this internship project. It did not hold me up because what I did have already was the account numbers, and I spent the rest of the time um, building the framework and building the model and the framework for getting the outcome data for readmissions and mortality, and um, uh, and matching the medical both the medical record numbers and the account numbers across the data sources.
Great, fantastic. So, last question, Dale. I'm just curious. Um, Now that we have a lot of students, it's hard for me to keep track of everyone. I'm just curious, how did you find out about CHIP, and what led you to join the CHIP program?
That's a fun story. So I can't, let's see how long, I think it was, I don't know, probably 7 years ago. And I essentially knew that's what I wanted to do. And I actually searched and really deeply investigated and took notes on every single master's in biohealth informatics degree in the entire country. And I somehow missed the one right here at Chapel Hill. And so I think the first year that this became available was the year I discovered it. My wife discovered it and said, "Did you know you could just do it right there?" And so I was floored and excited. But yeah, I guess the end of that answer is that my wife discovered it for me after I had kind of given up.
That's interesting. That's an interesting story. Yeah, no, I'm glad you joined us, and I'm so glad that you had a very successful, very nice experience in terms of concluding and bringing together the experiences, and I hope it was useful in terms of the learning that you had throughout. Anything we can do to continue to help you, we're here to help you. Thanks, Dale.
Thank you.
Dale, this is Larry Manliker. Can you hear me?
Yeah.
Hey, anyway, congratulations and terrific presentation, terrific work. I know we've talked before, and I'm really impressed with everything that you've done. I just wanted to thank you for sharing this and ask if I can follow back up with you. There's several projects that we're involved with. Again, certainly we're laying low and working on a variety of things with the COVID crisis. But when we come out of the tunnel on the other end of this thing, we'd very much like to follow up with you, both in terms of look at some of the analysis you've done, especially with some work that we're looking at around disparities and some of the analysis you've done in terms of stratifying your data by gender and by race and by gender and by other factors. And also would like to learn more about how you guys are looking to extract data directly from the record, and be able to avoid some of the manual abstraction, because I think that may have application in a variety of other registries. I would love to leverage the great work you've done to help others. So again, terrific work, and if you don't mind, I'll follow up with you at a later point in time.
Yeah, that's excellent. Thank you for joining. I appreciate that, and I absolutely look forward to that.
Terrific. Thanks again.
Hi Dale, this is Faye.
Hey, Faye.
And yeah, I want to say congratulations for the presentation and also your completion of the internship report. And I hope that your report can be accepted, as a research paper, as we discussed before. And here I also want to use this opportunity to add to that every other note that NC Tracks has the people there have looking at Dale as the go-to person for the similar projects. So in the future, if any students want to pursue very similar approach in very similar projects, you can ask Dale.
Absolutely. Yeah, absolutely. I'd love to. Thank you.
Mm-hmm.
Well, I think there are no other questions. So I want to thank you, Dale, for your presentation. We will be taking a very short break, 8-minute break, and we will reconnect at 2 p.m. for Tia Carmen's presentation.